Medurstand. Understanding Medicine.
I am Professor Aziz-ur-Rehman, and after discussion about the basics of endocrinology, the introduction of endocrinology, we are going to start with the pituitary disorders. And pituitary disorders are of two types. There could be excess of hormones or there could be deficiency of hormones. We will not be able to discuss every single condition in detail, but I would take up these excess of hormones today. And there are two main conditions which we'll cover. But before we do that, let's go through the basic hormones produced by the pituitary. Anterior pituitary, also called adenohypophysis, produces number one, growth hormone, and growth hormone is abbreviated as GH. I think all students and postgraduate students, they need to memorize these abbreviations because they are often mentioned in discussions, and you need to know them so that you get the concept better. So growth hormone, which is GH, it has got effect on the tissue, but most of the effects are mediated by an intermediary hormone produced by the liver called insulin-like growth factor 1, and that has got a stimulatory effect on the tissues. Basically, it increases the growth of bones and fat and muscle and everything. Very important hormone required for the growth of the children. And once we are grown to the full size, perhaps there is no much role of growth hormone. Then there's prolactin, PPL. It has got primarily inhibitory effect on gonads. So I'm not aware, though prolactin may be elevated in many conditions, it could be due to some tumor and some drugs, and we will discuss those conditions in detail later. And the adrenocorticotropin hormone, abbreviated as ACTH, is produced by the anterior pituitary, and it stimulates our adrenal cortex, and particularly the production of corticosteroid, glucocorticoid, and mineralocorticoid, and also some androgens. So that is important. Then we have follicle stimulating hormone and luteinizing hormone, collectively called gonadotropin, and they are abbreviated as FSH and LH. They stimulate the relevant gonads, testes and ovaries, and then they produce androgen as testosterone and estrogen. Thyroid stimulating hormone TSH stimulates thyroid gland and produces thyroxine, which is so very vital for our body function. So these are the hormones produced by the anterior pituitary. There could be excess of these and there could be deficiency of these, resulting in various diseases. Now take the example of posterior pituitary, and posterior pituitary is also called neurohypophysis because it is actually not the endocrine tissue in the sense that it does not secrete hormones, it only stores. There are two hormones. One is antidiuretic hormone, ADH, very important in the regulation of water. Its excess could lead to syndrome of inappropriate ADH secretion, which is usually a complication of another disorder, or there may be deficiency of this hormone leads to lot of diuresis resulting in diabetes insipidus. Then oxytocin is conditional hormone. I'm not aware of any role of oxytocin in men, but in women it stimulates contraction of uterus and mammary gland production of milk. So it is required for parturition and later lactation. Again, it is very important, released by the posterior pituitary. Now, this is actually a summary slide. Theoretically, any hormone of the pituitary can be in excess or there could be deficiency. So before we take up these conditions individually, let's go through this summary to have an overall idea. Growth hormone, if it is in excess, it may cause one of these conditions, one of these two conditions. Gigantism is a very tall person, and this occurs when growth hormone excess is during the growth age. In the children, if that is the case, then somebody will grow very tall. But remember, the people you must have seen in some circuses or some hotels, very tall guys, they may be tall due to something else, but gigantism is also one of the possibilities. But once you have achieved the full growth, you are already an adult, then growth hormone axis cannot increase your axial height. You cannot grow in height, but your peripheries, your hands and face, that grows up in size, and that condition is called acromegaly. Deficiency of growth hormone, maybe if it is congenital, it would result in growth retardation. But if somebody has already achieved his adult life and then pituitary is damaged, then there will be deficiency of multiple hormones called hypopituitarism. Now, prolactin hormone, if it is in excess, it causes erectile dysfunction in men and galactorrhea in women. And if it is deficient, then probably not much, no big deal. If prolactin is deficient, at least I'm not aware of any disease caused by deficiency of prolactin. Adrenocorticotropin, if it is excess, it is usually due to a microadenoma situated in the anterior pituitary gland, which produces ACTH that will stimulate adrenals. There will be bilateral adrenal hyperplasia. There will be a lot of cortisol in the body, and that will result in Cushing disease. Now, if ACTH is deficient, usually it would be a part of multiple deficiency syndrome, but the resultant condition would be called hypoadrenalism. And thyrotropin TSH, if it is in excess and the problem is in the pituitary, it would result in secondary hyperthyroidism. Of course, primary hyperthyroidism refers to a condition when the thyroid gland itself is at fault. If TSH is deficient, it would again be part of panhypopituitarism, but this particular component would be called hypothyroidism, secondary to pituitary disease. Then gonadotropin, if they are in excess in the growing age, it may result in precocious puberty. That means the puberty occurs at a very, very young age. If androgens are produced in excessive quantities, the features of puberty may develop at the age of very, very young age, like 4, 5, 6 years. Very embarrassing condition, but this can be cured by if we can identify the cause and correct it. And the deficiency of gonadotropin would cause infertility, both in men and women, because gonadotropin is not only required for the production of testosterone and estrogen, but gonadotropins are also required for the production of sperms and ova. So gonadotropin deficiency would definitely result in infertility. So this provides a summary of pituitary disorder. Today we are going to discuss two conditions where there is excess of one of these hormones. First is excess of growth hormone, and there is a tumor in the anterior pituitary that produces too much growth hormone, and that in adults would result in acromegaly. Now this is the picture differentiating between this person has got gigantism. These are two twins. This picture is taken from the book purely for the academic purposes. So these are twins. Normally identical twins are of the same height, but this guy has got a tumor in the pituitary, and he grew very tall as compared to his sibling. Now let's talk about the clinical feature of this disease. And number one, it is an extremely slow disease to develop. For example, if some family physician is looking after some patient for various diseases and he develops acromegaly, the features will develop so slowly that the family physician might actually miss it. Now, if somebody else sees that patient, he is more likely to pick up those features. In any case, features of acromegaly, they develop very, very slowly and are easily missed. The features are enlargement of hands and feet. Now you can compare the hands of a normal person with the person with acromegaly. The hand of acromegalic patient is much bigger. Similarly, feet, if this is the normal foot of a person, the same height person with acromegaly would have much bigger feet. So that is another important feature. Prognathism is actually enlargement protrusion of lower jaw. In some patients, you can see this. Now, this is again a picture taken from the internet. This disease, acromegaly, is not very common. But since these patients, they live almost normal life, at least very long life, and they are seen by most physicians. So you will see the same picture in various presentation. This is taken from the internet, and you can see the prognathism. The lower jaw is protruding, and there is also widening of the teeth. You can see the space between different teeth is increased. These two features may be seen in normal person also, but these are features of acromegaly also. Then we have visceromegaly. Every organ is likely to be bigger, like heart is likely to be bigger than normal, liver, spleen, kidneys, every organ is likely to be bigger in patient with acromegaly, but they are not very diagnosed featured. Then headache may be a common symptom. Headache will occur only when the tumor is fairly big. Now I have pulled this picture to show you the anatomy of the pituitary gland and also explain some of the clinical feature. Now this is the pituitary gland, just the size of a pea, sits in pituitary fossa. Above it is optic chiasm, and then we have carotid vessels. These red are carotid vessels. Then we have this cavernous sinus. We have these nerves, the fourth nerve, the fifth nerve, the sixth nerve, and seventh nerve. No, not sixth nerve. I think fourth, fifth, and seventh nerves. And so these are very vital structure surrounding pituitary gland. So if this tumor grows and grows to the size that it actually expands this pituitary fossa, it is likely to cause central headache which is situated deep inside. Then there could be visual impairment. Just above pituitary gland is optic chiasm, and if optic chiasm is compressed, then you will have pituitary the visual problem. Would indicate that the disease is already advanced and there is a kind of urgency to remove the tumor to save vision. And then cranial nerves involvement. All these cranial nerves, apparently they are situated at quite a distance, but sometimes the tumor may really grow very big and can compress on one-sided or both sides nerves, and various nerves may also be paralyzed. Then there may be carotid involvement. These are quite close to the pituitary gland, and carotids may be compressed or may be destroyed by a growing tumor. And this would apply, many of these clinical features would apply to any pituitary growth, any pituitary tumor. Today we are discussing a growth hormone producing adenoma, but these would actually apply, this headache and visual impairment and cranial nerve involvement and carotid involvement, they would apply to any pituitary growth. Then entrapment neuropathies, particularly in acromegaly, because when the tissue grows outside, it also grows inside, and our nerves pass through many tunnels and narrow places, so they can get compressed, and you could end up having various neuropathies like foot drop and wrist drop and other carpal tunnel syndrome, things like that. Investigation of acromegaly. First of all, it just makes sense that we will go for growth hormone, and as a student you would expect that growth hormone will be in excess, and that is the case actually. But the problem with growth hormone, like many other hormones, is that growth hormone is produced in pulses. So there is a peak and then there is a nadir. So if you happen to collect sample at the time of nadir, then you might just miss the actual level of growth hormone, and growth hormone has got a very short half-life. So instead of growth hormone assays, more popular is growth hormone suppression test. Now we would give something which should normally suppress growth hormone, and if that happens, then we will see that the growth hormone is normally behaving. But if despite inhibitory stimulation, inhibitory factor, growth hormone stays high, that would mean that growth hormone production is abnormal, probably indicating a tumor. Instead of growth hormone, we measure growth hormone suppression test I've already talked about. That is more sensitive than the growth hormone assay itself. Then somatomedin, which is also called insulin-like growth factor. This is the surrogate marker or surrogate indicator of growth hormone. Growth hormone produces its effect in the body through insulin-like growth factor 1, and it has got much longer half-life. So if there is pathological hypersecretion of growth hormone, IGF level is likely to be high, and we can measure it, and then we can infer that the growth hormone is actually increased. X-ray skull lateral view to see the pituitary fossa. If there is a tumor, any tumor, it may be growth hormone producing tumor, or it may be another tumor, it may be a non-functioning tumor. So any tumor is likely to expand the pituitary fossa, but you must know that this would take long time, and we don't want to wait that long. So this is seen only in those patients who are neglected or who do not present to their doctors early, and only very late there may be enlargement of the pituitary fossa, which can be picked up on X-ray on lateral view. MRI of pituitary gland, of course, the most sensitive imaging test is MRI, and if we suspect an adenoma in the pituitary gland, we order MRI. But for students, I think it is important to mention to the radiologist what you are suspecting. Just a routine MRI of brain would not pick up pituitary tumors. So you have to specify in the request form that you are suspecting a pituitary adenoma, and if possible, you may also indicate what kind of pituitary adenoma, so that a radiologist gives you the right imaging. Axis skull, now two axes are compared. This is normal, and my cursor is in the pituitary fossa. This is the pituitary fossa. You can see the size. This is the size, and this is, I think, sphenoid sinus. This is the skull, and you see this one much bigger. This one is much bigger than this because there is a tumor inside. It is sort of ballooned out, and you can also see the double flooring. This double flooring is also a sign of pituitary tumor on axis skull. But I would like to mention again, it will take long time, maybe years and decades before this thing develops, so we can't really rely on X-rays to pick up pituitary tumors. MRI is very sensitive. This is a classical example, an image taken from the internet. You can see this enhancing lesion. This is a big pituitary growth, and it is going above sella. So this hump is indicating that it has gone above sella, and it is pressing on the optic chiasm and must be producing some visual symptom and headache because it's too big. And this is the frontal view. Same can be seen in cross-section view. This is the pituitary fossa, and you can see the tumor which is expanding laterally also. I think, if I'm not wrong, it is perhaps eroding the bone here. And it is also, this is the optic nerve, this is also compressing on the optic nerve. Then we have sagittal view. In sagittal view, you can see this big tumor protruding into the sphenoid sinus and also upward into the optic chiasm. So with three images, you can have a fairly good idea what exactly is the size of the tumor, and surgery can be planned accordingly. Approach to pituitary masses. As I said, whatever mass in the pituitary may be, the approach would be the same. Now it depends on what kind of approach we will take, depends on size and extent. If it is small tumor, a microadenoma, and not producing any complication due to its size, and it is metabolically not active, so it's non-functioning tumor in the pituitary, we can just wait and see. We may not do anything. But if it is uh, hormonally active, we may try to treat it hormonally also. But if it is big and is producing mass lesion and is causing headache, then of course we will go for surgery. Headache is another indicator. Headache in a person with pituitary mass would indicate a big lesion. Infiltration of optic chiasm, of course, vision is very important. It is a classical visual pattern in this condition, bitemporal hemianopia. So I think if that is the case, we know that there is already, actually we are late, so we have to remove the tumor as early as possible. Cranial nerves, third, fourth, fifth, sixth nerves are present in this neighborhood of the pituitary. They can be paralyzed, and hormonal function excessive deficiency. We take all these in consideration to plan the surgery or plan the treatment. So treatment may be on one extreme, just wait and see. On the other extreme, there may be straight away surgery, or in the middle may be hormonal treatment. Wait and see in small non-functional lesion. Somatostatin LAR, this is actually a substance which inhibits the secretion of growth hormone. Now, in some cases, if there is a tumor in the pituitary gland which is producing growth hormone but is not causing uh, any pressure on the nerves or the optic chiasm, then we may just give somatostatin LAR, which is injection given periodically once a month or once a week. Then bromocriptine also has inhibitory effect on the uh, pituitary gland and especially the growth hormone producing cell. That may also be used to reduce the level of growth hormone, and of course ultimate is surgery. Because pituitary is a very small organ and approach to the pituitary gland surgically is not easy, and it's a very advanced surgery, so this is done only in some specialized center. If there is a small tumor which is manageable with the hormonal therapy, then we wait for the surgery. Two approaches. This is the modern trans-sphenoidal versus craniotomy. Now this is the modern. You can see the surgeon approaches the pituitary through the nose and then the sphenoid sinus, and then he can resect the tumor from here. Sometimes it is not possible to remove the entire tumor if it has gone to the cranium already, but the small tumors can be removed from this. This is easy. This is good approach for the patient because there will be no scar, there will be no craniotomy, and I think much better than craniotomy. But if the tumor has gone above the brain, above the sella turcica, then it has to be taken from above. Now look at this ugly big scar, but sometimes we have to go for this. And many times it is a joint work, and some part of the tumor is removed by an ENT surgeon through the trans-sphenoidal approach, and the remaining tumor is removed by the neurosurgeon from the craniotomy. And the aim is to save as much as possible, to save the normal pituitary as much as possible, and to remove the tumor as completely as possible. Now, another condition we have done with this acromegaly, another condition where there is hypersecretion, just few slides, and this is Cushing disease. The tumor may produce ACTH, and this condition is called Cushing disease. Now, clinical features are Cushing disease. What is Cushing disease? A microadenoma in the anterior pituitary which produces ACTH. ACTH will stimulate both the adrenals. Adrenals will be hyperplastic. Adrenals will produce too much cortisol, and androgens, and that will result in these features. And I think I have discussed in adrenal diseases in more detail. So here, just a brief introduction. There will be moon-shaped face. You can see the bloated and the fat deposition and shining and rounded face. It's called moon-shaped faces. Hypertension, obesity, and these stria are very classical. Investigations in Cushing disease, specifically in Cushing disease, if we do ACTH, guess what will be the result? It will of course be high. But remember, you may not have very high ACTH because these are functioning tumors. They produce ACTH and in the form of pulse. That pulse goes to the tissues and goes to the adrenals. But actual level of ACTH in the plasma may not be very high, maybe actually within upper normal range or maybe only slightly elevated. So ACTH is expected to be high, but only minimally so. If you measure serum cortisol, and we know that there is a timing of when you can measure serum cortisol, best is 8:30 a.m. before breakfast, or it could be 5 p.m. also. Serum cortisol is likely to be high. We are talking about Cushing disease. There is another condition called Cushing syndrome, iatrogenic Cushing syndrome. In that, cortisol may be low because actual glucocorticoid, which is causing Cushing syndrome, is not cortisol. Urinary ketosteroids, if we measure 24-hour urinary ketosteroids, they are likely to be high. And if we do pituitary MRI, then we will find a tumor, microadenoma. Microadenoma because is defined as a tumor which is smaller than 1 centimeter. It's an arbitrary definition. And we use this word because microadenoma or any adenoma which is less than 1 centimeter is unlikely to cause physical symptom due to its mass, but it will produce symptoms, the signs through the hormone. So this one is producing ACTH and is producing Cushing disease. So adrenal ultrasound will be done and CT will be done and MRI will be done, and guess what will be the result? If there is ACTH, it will of course stimulate both the adrenals. So there will be bilateral symmetrical enlargement, hyperplasia. It is, I believe, they may be normal at a certain stage because adrenal glands are so small, little bit of hyperplasia may not be picked up by the CT scan or ultrasound. So it is the collective information, the history, the physical examination, and this hormonal assays and imaging tests that lead to the correct diagnosis. That was all for today, and I look forward to see you in my next presentation, and that is going to be on deficiency of pituitary hormones. Thank you very much.